A middle-aged, right-hand dominant, Scottish descendant supervisor comes with symptoms of progressive right ring finger contracture. He denies any previous history of trauma. His dad also had a similar contracture which was operated. He denies any history of diabetes mellitus or medical illness, and he is not on any medications. On assessment, a prominent cord is noted in the palm in the line of the ring finger, extending to the level of proximal interphalangeal joint flexion crease. There is a prominent nodule present on the palmar aspect of the proximal phalanx with a 60-degree flexion contracture of metacarpophalangeal joint and 10-degree contracture at the proximal interphalangeal joint. He does have similar symptoms on the left side, which shows early palmar disease. No knuckle pads were noted and there is no involvement of plantar surface of the feet. An X-ray was performed by the GP, which was normal. A differential diagnosis in such situation can be Dupuytren contracture, joint flexion contracture, scar contracture, flexor tendon bone shrinking, tendon adhesions, or tumors such as fibrosarcoma. Dupuytren disease is attributed to the genetics of Viking heritage and Northern European lineage with the autosomal dominant pattern of inheritance. The condition presents most frequently in males and often in the age of 40s. Clinical feature includes painless, palmar pitting cords and nodules frequently in line with the small end ring finger. Many structures described as bands or ligaments in their normal state are referred then after as cords. The spiral cord is a continuum of the disease from the spiral band, lateral digital sheaths, and Grayson ligament. The spiral cord is pulled to the midline with contracture, causing the neurovascular bundle to wrap around the straightening of the tightening cord. The natatory cord can be palpated in the web space, as its contracture deviates the digit from the midline at the metacarpophalangeal joint. Disease progression generally leads to contracture of flexion deformity of metacarpophalangeal and interphalangeal joint. Associated findings include dorsal knuckle pads that are called garrote pads, thickening of the plantar tissue in the foot that is called leather horse disease, and penile fascia as a Peyronie disease. Indication for surgical correction of Dupuytren contracture depends greatly on the impact of the deformity on the patient's ability to perform functions of the daily living and willingness of the patient to participate in post-operative rehabilitation. Hard and fast objective surgical indications are difficult to find. A Houston tabletop test is the earliest sign of significant flexion contracture, although this test alone is not always the indication for surgery. The test is positive when the patient cannot fully flatten his or her hand against the table surface. Generally, flexion contracture of metacarpophalangeal joint are better tolerated by the patient and are relatively easy to correct. The metacarpophalangeal flexion is a relatively safe position that maintains the collateral ligament length. But on the other hand, in the PIP joint, interfere more with the hand function and are more difficult to correct. PIP flexion is a relatively unsafe position that allows the volar plate to contract. Therefore, PIP flexion deformities are stronger indication for surgery at early stages than MP joint deformities. At the microscopic level, Dupuytren tissue demonstrate abundance of normal fibroblastic and myoblastic cells. The local abundance of these cells explains some of the molecular findings attributed to the Dupuytren tissue, such as increased amount of type 3 collagen. The fibroblastic and myofibroblastic proliferation has been localized around occluded microvessels and seems to be a cellular response to the local tissue ischemia. This may explain the association of Dupuytren contracture with conditions that predispose to tissue ischemia, such as alcohol use, smoking, and age. The myofibroblast shares cellular characteristics between fibroblast and smooth muscle cells and concentrated within the palmar nodules. The contractile element of these cells type produce a progressive pull through the Dupuytren cords that leads to the contracture deformity. Residual myofibroblasts within the dermis and the epidermis after surgical excision of the diseased tissue have been implicated to have the recurrence of the contracture. The notion is supported by the low recurrence rate with palmar skin excision and full thickness skin graft after fasciectomy, also called fire break. Regarding this patient, the patient was treated with a subtotal palmar and digital fasciectomy. He was brought to the operating room under an auxiliary anesthesia block. Brunner incisions were utilized by exposure of the pretendinous cords. An early spinal cord was encountered at the level of PIP joint. After both neurovascular bundles were identified and protected, which is mostly done from the proximal aspect, the involved palmar fascia was excised and sent to the pathological laboratory for gross histological analysis. At the conclusion of the procedure, complete correction was obtained at the MP as well as PIP joint. The tourniquet was deflated before of closure, and a brisk capillary fill was noted immediately. The wound was closed with interrupted 5-0 nylon sutures, and a short arm plaster splint was applied, immobilizing MP joint at high degree of flexion with PIP joint comfortably extended. In some situations, some surgeon would prefer not to deflate the tourniquet and apply compressive dressing before deflating it. Postoperatively, the patient is followed up with the examination done on third postoperative day, at which the patient dressing is reduced. A hand therapy referral is sometimes done, and this can be done by the hand therapist as well. Inspection revealing minimal swelling with a well-vascularized flap is noted. A light dressing is applied and occupational therapy is instituted with a certified hand therapist. A resting night splint is fashioned with the ring finger in full extension to be worn for 3 months. A follow-up with 3 months reveal excellent wound healing with full recovery and full flexion. When you talk about the alternates, there are no proven non-operative modalities that can reverse or halt the progression of the cords, nodules, or contractures. The significant number of patients develop progression of the flexion contracture and involvement of the digits, although the risk and the rate of progression are variable and difficult to predict. The unpredictable natural history of this disease may present a sense of efficacy to some patients who try non-operative modalities, and they should at least be counseled accordingly. There was a promise regarding collagenase injections, but it is not available now in United Kingdom. Historically, radical palmar fasciectomy was performed in an attempt to get rid of all the disease tissue. However, recurrence is still noted, and this procedure has fallen out of favor due to associated complications and patient morbidity. A segmental fasciectomy has been described, a method of correction the flexion contracture with segmental excision of diseased tissue, although through multiple incisions. Full thickness skin graft at these multiple incisions can theoretically prevent recurrence at those sites and provide fire breaks against the full length cord recurrence. Skin grafting technique can also be done in conjunction with standard partial fasciectomy. Fasciotomy can be performed through a limited exposure to release the cord and provide correction of the contracture. This procedure does not attempt removal of diseased tissue. However, it does provide a method of contracture correction in a debilitating patient. In severe or recalcitrant deformities can ultimately be treated with amputation or ray resection. In such cases, all involved palmar skin should be excised and free skin graft or dorsal skin should be utilized for the flap coverage. Correction of the contracture changes the lay of the palmar skin and may present areas not amenable to direct closure of the original skin incisions. Direct incisions, different incisions, and techniques related to wound closure have been described. Generally, a Brunner zigzag incision is used in less severe contractures and can be closed in a VY fashion to add coverage. The transverse limb or VY closure can be left open to relieve skin tension. In more severe contracture, the straight line incision is done and multiple Z-plasty angle to provide good exposure of the increased palmar skin length at closure. Ultimately, the finger can be flexed to gain direct closure, and a small parts of the incision over the finger can be left to granulate. There is also another technique called McCash open palm technique that leaves the palmar part of the skin incision open to gain length. After the surgery, the wound is cared of for daily dressing, and closure of the wound is seen in 3 to 5 weeks' time. Some have used the open palm technique routinely and report a lower complication rate with a better motion with this technique. The complications which can arise from Dupuytren contraction can be vascular compromise, hematoma formation, skin sloughing, loss of flexion, recurrence of disease, or reflex sympathetic dystrophy.